Cheryl, there's a highly illuminating booklet called 50 over 50, which is a series of interviews with around 50 people as they age with HIV. And there's some very moving, actually, stories in there and descriptions of lives and what impact the care services have on them. And mental well-being was a really powerful theme through those stories, including people living with loneliness, people still tackling or facing the issue of stigma. Where does mental well-being fit into this picture?
Well, I think it's a key point, and it's something that we've done research on, not specifically actually with the ageing population, but there are generic mental health services which suit some people living with HIV, but there are probably about half the people who have those broader mental health needs don't feel like generic provision is suiting them. So actually they are looking for HIV specialist provision. And we think that if you actually can embed those mental health services properly within HIV clinics, you're much more likely to get a sort of smooth progression of people into mental health services. But there's the other side of that where people perhaps don't necessarily need such intensive treatment, such intensive response. And the value of peer support and support services is huge. And that's one thing that we are really hoping that might come back with ICS, is because they sort of fell out the picture. They had no commissioning home after the 2013 changes. And some have been maintained and some are still funded, but they're incredibly valuable, incredibly economically efficient. You know, the voluntary service isn't free, but it's not as expensive as perhaps some more intensive services. And so being able to sort of build up that provision and that support, and that can be a really strong sort of mental health support and prevent people actually needing the more intensive mental health support. So I think there are two sides to that coin.
Right, so it's another aspect of prevention, isn't it, or early intervention,
Absolutely.
Early support, and peer support, as you say, can be so valuable. Ruth, mental health services are under possibly even more strain than every other part of the health and care system at the moment. It's easy to see that people with HIV may not be at the front of the queue when one looks at problems such as young people with mental health needs. What are your thoughts on on how ICSs can meet the mental health needs of people with HIV?
So I think some of this comes back to measurement again, and one of the things we're really keen to do to address health inequalities and inclusion health is look at equity ratios. So we're able to say, for example...
So could you explain that term?
Yes, I'm about to. Yes, don't worry.
Sorry.
So equity ratios look at your kind of prevalence in a general population, and then how many people are accessing services. So an example that I often give is you might say 18% of Enfield's population are black, but 35% of people accessing serious mental illness services are black, and 8% of people accessing lower level mental health services are black. So you can already see that equity ratios show that higher numbers than we would expect are accessing the severe mental health services, and much lower numbers than we would want are accessing the lower level mental health services. And I think I think it's a really good idea to look at something similar for HIV. So to kind of pick up, what would be the expected prevalence, where are we seeing higher than expected, and where are we seeing lower than expected, and then how can we all work together to understand how we get to the root cause of that.
Jim, using data is obviously what you do, isn't it, as a public health director, and as Ruth's alluded to a couple of times now, this is such a powerful and important aspect of identifying need and meeting need and distributing resources. So where does that measurement issue come into this debate?
My not very inner nerd was purring as Ruth was talking, I have to say. You had me at equity. I was waiting for you to talk about slope of inequality, but to be serious, I think I'm old enough to remember the times in the 90s when we started needs assessments for gay and bisexual men as a tactic to get health equity. And I would say if you take a public health approach, and not what everybody else calls a public health approach, but you start from what does the data say? What does epidemiology say? What does the evidence say? use the joint strategic needs assessment process and sit down together and get an idea of the population.
And that's the way that health and local authorities have a combined view, isn't it, of what the needs are of their population.
It is, and it's part of the, I mean, it's a statutory mechanism, but it's part of the glue that binds us together psychologically into a system, and I think that's really important. You begin to use that data, plus the rich data that people living with HIV can provide us that we haven't got. So you need that kind of qualitative lived experience alongside the data, and particularly on mental health. When one of the things we need to realise about mental health is that we can no longer treat our way to mental good health. It's impossible. Employment has a major role to play, so does education. But actually, we know, there's lots of evidence that the positive impact of peer support for all sorts of things can help people deal with low-level mental ill health and mental unwellness, and can help them be resilient. And one of the things we haven't done with HIV, and I don't know why, is we haven't developed a recovery approach to mental health with HIV. We haven't developed that resilience approach. And actually, some of the pioneer organisations had it 20 years ago. You know, so, and I remember them doing it, and I remember discussions about it. So there are things we can take out of that if we sit down as a system. And one of the problems with system working is that, so forgive me, this might sound blunt, but sometimes there are partners who if they don't control it, don't feel they understand it. Now's not the time. Actually, we need to sit down and go, we've all got a piece of the jigsaw, we're all a part of the system. And maybe a good place with HIV is to start either with women's health or mental health or PrEP, an area where we all have to work together to crack it, or indeed comorbidities.
Yes, I mean, PrEP was an example where there was some conflict in the system, wasn't there, about how it should be rolled out and about accessibility and so forth. So it's important to learn those lessons.
Yeah, and absolutely. And, you know, local authorities, we had our grants cut by in real terms by a third. Whereas actually the amount of money that NHS England saved by switching to generic antivirals was significant. So I think there is something about recognising our ambition, but also recognising who's got the money, who's got the other levers, who's got the non-money levers, and coming to the table as a group of equals with people with HIV front and centre, maybe even convening the meetings, as I've seen in some ICSs where they've done a brilliant job.